All right. Um, Good evening to everyone. We're running a little bit uh, behind schedule. Welcome to everyone again to another emergency medicine quarterly grand rounds, the social distance edition. I hope everyone who has attended is wearing their mask. Right. I am Dr. Patrick, and I will be the event moderator. All right. So today we will be talking about an interesting topic during this extended hurricane season, calming the storm, updates in the management of refractory uh, ventricular fibrillation and ventricular tachycardia. The program this evening will be a case-based presentation by one of our residents, and also we'll be entertaining questions and answers on the case, and also a discussion again by another of our residents, and question and answers as well allotted through the discussion. All right. So before we start, we'd just like to highlight that we have some special guests or guests that are coming. Um, I apologize for the name pronunciation in advance. Dr. Binoy Shatuparambil, uh, cardiothoracic surgeon which is also the clinical director of the Health City Hospital in Cayman Islands. Uh, and Also, we are expecting our local electrophysiologist, Dr. Claire Pasco. So we'll have those persons with us as well. So without further ado, I would like to open now with a word of prayer by our Dr. Pierre, a first year resident in the emergency program.
Good evening, everyone. Let us all place ourselves in our preferred mode of reverence as we bow our heads in prayer. Most merciful and wonderful Lord, maker of all things good, powerful and ever-loving God, as we gather today, we'd like to firstly say thank you. Thank you for waking us this morning so we can see this beautiful day. Thank you for health. Thank you for the food on our tables. Father, in these trying times, we remember those who we try our best to assist on a daily basis, the sick and the dying, those who we have lost to this pandemic and their loved ones. Father, thank you for keeping us safe in these times. And as we navigate these current storms in our lives, Lord, we put before you a different storm today, electrical storms, Father. Please come, Lord, and be part of our grand rounds today as we share and learn and interact about this very important topic. Bless the presenters, Lord. Bless the organizers, and bless all present. Open up our minds, O Father, that we may take from this what you so desire. And last, Father, but not least, we would like to put before you our colleagues who have written their DM exams over the last 2 days. We pray for only passing grades, Lord. Father, we say thank you. Rather than just pray, we say thank you for only passing grades, Lord, because we know that you have done it. and that you have made them successful, Lord. Once again, Father, we say, come and be part of this program today. Come and bless us with knowledge, Lord. All of these we pray for and we thank you for. In your precious name, amen.
Well, okay. I had no idea we had a resident pastor amongst us. Thank you again, Dr. Pierre. All right, so just to start off, for us to understand that a little bit about refractory ventricular tachycardia, or also known as electrical storm, a relatively uncommon but potentially life-threatening type of arrhythmia. So you will have to understand that in terms of getting to know it better, I actually put together a questionnaire, to see where we're at in terms of the knowledge base, how often or frequent you may come across this type of lethal arrhythmia. So with this pilot survey given amongst our staff, we found that amongst the 164 responses about what is an electrical storm, about 73% actually got it right? But I'm hoping the others who were unaware will now be aware after today's grand rounds. Also, we also had 90% correct type of response in terms of the knowledge of the arrhythmia is common in. And we see where you have your heart failure or your myocardial infarction or your inherited arrhythmic syndromes and your implantable cardiac defibrillatory devices. In terms of the prognosis, about 80% of the person are aware that, as you can understand, it has a poor prognosis. And in terms of around each person had a general idea of the type of rhythm in terms of that's associated with electrical storm. And we know now that it's the ventricular tachycardia. And in terms of the common electrolyte abnormality that precipitates this type of arrhythmia is hyponatremia, and about 79% of our pilot sample gave that correct answer. And in terms of how common, amongst our 164 responses, we got around persons not really being aware of this type of arrhythmia, and around less than 0.4% ever had any interaction with this type of rhythm. In terms of the best therapies, most persons got it right in terms of the pharmacological options available in terms of management of this type of lethal rhythm, amiodarone and propranolol. So with that said, hoping that I have able to pique the interest of my viewers today, and we will be going over and trying our best to highlight the type of potential updates and steps in the management of electrical storm. And we want to do this with any type of pathology through a case-based type of presentation. And doing that will be our first year resident, Dr. Waldron, right? And I'll put it over to Dr. Waldron now.
Good afternoon. Good afternoon, everyone. Again, my name is Dr. Waldron, and I will be presenting the first half of our case today, Calming the Storm, updates in the management of refractory ventricular fibrillation and ventricular tachycardia. So we start with our case. The patient CD, who arrived in the accident emergency department on July 30th, 2020 at 7:22. He was triaged to category level 2. He is 41 years of age. Now, the patient was uncertain of his medical history and was referred to the University Hospital on that date from the Heart Institute for urgent admission to telemetry with the need for coronary angiography plus or minus angioplasty. Now, the presenting complaint was that of mild chest, well, not mild, sorry, diffuse chest pain across the anterior chest wall. This chest pain was graded 8 out of 10 and had been intermittent over the past 3 days. It was pressure-like in character and sudden. There were no associated radiation of the pain, aggravating or alleviating factors. The patient also presented with non-productive cough, as well as post-tussive non-projectile vomiting. This was all on a background, a 4-month history of noted decreased exercise tolerance, 3-pillow orthopnea, paroxysmal nocturnal dyspnea, as well as palpitations. Now, there were previous manifestations of similar pain in early July of this year, which required admission to hospital. The particular clinical course was about 4 days in duration. Now, as we can see here, our patient was on a host of medications in keeping with secondary prophylaxis for myocardial infarction as well as for heart failure. There were no known food or drug allergies. Now, with respect to our patient's past medical history, he was noted to have had a myocardial infarction in the past, dilated cardiomyopathy, atrial fibrillation, a hiatal hernia, as well as an upper gastrointestinal bleed. Unfortunately, the dates of these not too certain of. The previous admissions for the patient, again, in earlier July, was between the 11th to the 14th. And at that time, there were no recorded ICU admissions. Now, we get into the meat of the matter. The patient had numerous cardiac arrests prior to transfer. And they were dated as follows. On the 28th of July, he had 4 episodes. On the 29th, he had 1. And on the 30th, he had 15 prior to arrival at University Hospital. Now, he required multiple pharmacological agents, being amiodarone, lidocaine, as well as magnesium, multiple defibrillations, max doses, the monophasic at 360 joules, and biphasic of 200 joules. And at each point in time, obviously, ROSC was achieved. Now, if you're of a younger generation looking at this, you'd probably be like, that? And if you're of an older generation, my generation, you're probably saying this. So, moving into the past surgical history, the patient didn't have any contributing, or there was no surgical history. With respect to the family history, it was surprisingly negative for cardiac disease, sudden cardiac death, dyslipidemia, thyroid disease, autoimmune disease, diabetes mellitus, as well as hypertension. And there was no contribution with respect to the social history from cigarette use, alcohol use, or illicit drug use. Moving on to the examination, patient came in on arrival, and the vitals were as follows: blood pressure of 103/66, heart rate of 80, respiratory rate of 24, temperature of 36.8, and an oxygen saturation of 98% on room air. He was not in any acute distress at the time, surprisingly. Was anicteric, acyanotic, and afebrile. With respect to the cardiovascular examination, we appreciated the apex to be displaced in the 6th left intercostal space in the midclavicular line. The first and second heart sounds were appreciated without any added sounds, no murmurs, and there was appreciated pedal edema up to the knees bilaterally. With respect to the respiratory examination, manual recount of the rate was 18. Vesicular breath sounds were heard throughout all fields, and air entry was equal. There were no adventitious sounds appreciated. With respect to the abdominal examination, that too was unremarkable. It was soft, non-tender, without any guarding, no organomegaly, and bowel sounds were heard throughout. And the patient was alert and oriented to time, place, and person with normal bulk, tone, full power in all limbs. Now, I pause at this point because during the examination, the patient had immediately post-examination, the patient suffered his first event in A&E. This was approximately 17 minutes post-arrival to the department. The patient had displayed decreased responsiveness, and he was in cubicle 1, already hooked up to a monitor, and polymorphic beef tack was actually appreciated on the monitor. Now, A&E personnel were already donned in protective equipment, so there was no delay in administration of care. And a shock was actually delivered at 200 joules. Once that shock was delivered, the patient reverted to sinus rhythm, and it was then thought to place the patient on amiodarone at 0.5 milligrams per minute. Now this here is an ECG. I apologize for the shadow, but this was the ECG that the patient had upon arrival to the department. I don't think anyone in Zoom can actually comment on this. All right, so I'll go through this ECG. This ECG What we're appreciating here was what we thought to be VTAC, and the criteria in which we used in order to appreciate that was actually the Brugada criteria, which would you use to determine whether a wide complex is actually due to VTAC. It has 4 criteria. The first being, is there any concordance present in the precordal leads from V1 to V6? 2, is the R to S ratio, R to S interval greater than 100 milliseconds in any precordal lead? 3, is there any AV dissociation? And 4, in examining the morphology of the QRS segment, we're looking to see if it meets the criteria of VTAC. And what you're doing in V1 is looking to see if there's an upward deflection versus a downward deflection. And the upward deflection, you're looking to see if there's an RS, R prime, or right bundle branch type pattern, and if it's a negative deflection, if it's in association with the left bundle pattern. And these things together will give us an idea as to whether or not we're actually looking at VTAC. This was the patient's ECG prior to his arrest. And at one point we note here the pause where he was actually shocked, and then we are showing the post-shock rhythm. I'm sorry, but I don't have the printout of the sinus rhythm 12-lead ECG that was done right afterwards. So his assessment was that of decompensated heart failure, ventricular tachycardia storm, and hypertension. Now, what was the plan? Moving forward, he was to have an IV access established, a complete blood count, urea and electrolytes, calcium, magnesium, phosphorus, as well as troponin. The plan was to continue the amiodarone infusion, as well as cardiac monitoring, and he was to be referred to the relevant services, medicine, cardiothoracic, surgery, as well as intensive care. Laboratory investigations ordered. Of significance, patients had a markedly elevated troponin at 250. Sorry. And he was also noted to be hypocalcemic. With respect to the troponin, that was thought to be secondary to the defibrillation that the patient had undergone prior to the labs actually being taken off. Now, this here is the most recent 2D echo from the Heart Institute in Mandeville. Now, of note, we can note here that the patients, when we're looking at the echo dimensions, a lot of these parameters can actually be observed in the parasternal long axis. But of note, we're looking here at the ejection fraction, and we can note that it is markedly reduced. Other areas that were commented on were the left-sided structures, in which we can, it was noted that there was moderate to severe increase in size in the left atrium. With respect to the left ventricle, there were regional wall abnormalities, particularly akinesis on the anterior septal, basal, and mid portions of the left ventricle. Now, with respect to the results, the report noted that there was general valvular, there was actually severe dilatation of the left ventricle, systolic function reduction, as well as an ejection fraction of 26 to 28%. Coronary artery disease, in which there was a left ventricular wall abnormality, generalized as well as regional dysfunction, which was suggestive of ischemic cardiomyopathy, and regional dysfunction, which was suggestive of an old myocardial infarction. He also had diastolic dysfunction, which was noted, and they noted that there was left ventricular diastolic dysfunction due to elevated left ventricular filling pressures. This here is just a still of the bedside echo that I attempted to garner on the patient. We can see here the view on the left is the parasternal long axis. And as I orientate people, can people see my, I don't know if I have a pointer. Yeah. Okay. This area here is our left ventricle, left atrium, sorry. And it flows inward. This is the, the blood is flowing in this direction into the left ventricle here. Here we have our outlet system and our aorta, and the cusps are here. And on the right, we have parasternal short axis view, in which we are looking, if we were actually able to see this actually in motion, we would see an actual squeeze of the actual left ventricle itself. And then these areas here are your papillary muscles. So I'm going to take you through a timeline of events that happened in the emergency department so we get a better understanding of where we are with this patient. So we start with the first time period of 7:39 or 17 minutes post arrival into the department, where we had noted that the patient had his first episode of cardiac arrest in the department. The second event occurred at 8:55. That should be PM, not AM. The patient again was found to be unresponsive. At this point in time, the fib was actually demonstrated on the cardiac monitor. ACLS protocol was instituted. One cycle of CPR was commenced, and the patient was ultimately shocked, receiving 200 joules. At that time, it was decided that a magnesium sulfate infusion would be commenced at 2 grams in D5 water over 15 minutes. Now, as ROS was achieved, our patient was relatively stable until about 3:30 in the morning, when, again, he suffered another event. BTAC was displayed at 234 beats per minute, and he then converted into ventricular fibrillation. Again, similar protocol was followed, patient was shocked, and ROS was achieved. Okay, so right now we are up to 3 events that have happened in the emergency department since arrival. So now with respect to our consultation services, internal medicine arrived in the department promptly at 8:30. They reviewed and assessed the patient, and their assessment was that of drug refractory ventricular tachyarrhythmia, status post cardiac arrest, ischemic cardiomyopathy, as well as atrial fibrillation. And their plan was to, again, continue the amiodarone infusion at the same rate over 8 hours. There was consultation to be made with cardiothoracic regarding temporary pacing. And the cardiac monitoring was to remain continuous, and he was for ICU admission and, again, cardiac catheterization. He was for angiography. And cardiothoracic reviewed the patient as well. They had basically concurred with the internal medicine assessment, and their recommendations was for that of a single chamber implantable cardioverter defibrillator. Now this device is not actually here on the island, and arrangements were attempted to be made with the family by purchasing the device in ICU B, and then the device itself would have been shipped to Jamaica. We're uncertain of the actual estimated time that would have taken for the device to arrive here in Jamaica. I just wanted to take a short bit of time just to familiarize some persons with an ICD, especially those who don't commonly come across this in practice. Now on this X-ray, we can see a generator, which is generally larger than that of a pacemaker, as it will have a capacitor to store the shock charge. Along the course of it you'll have 2 areas which are thicker. These are the shock coils. So we see that here, and we see that here. One is in the SVC and the other is in the right ventricle, and different configurations can actually exist. In addition to defibrillation, ICDs have an anti-tachycardic pacing function, which will attempt to stop reentrant ventricular tachycardia by briefly pacing the ventricles at a rate faster than the VTach before switching into defibrillation. Now, the anti-tachycardic pacing is usually delivered in bursts of 8 or roughly 8 impulses with at least 2 attempts made prior to delivering a shock. Now, moving back, anesthesia and the anesthetic service came to the accident emergency at around 1:15 a.m. They had determined at that time that the patient met criteria for ICU admission. Cardiac monitoring was to continue. Oxygen therapy was set with targets greater than 95%, and we were to avoid hypoxia in this patient. We ensured, the plan was to also ensure anticoagulation. The patient was to remain NPO, and there were targets set for the GMR as well as the urinary output. A systematic review was performed by the ICU resident, was in keeping with that which was previously found. And the plan was, again, in addition to what was previously noted, to monitor the electrolytes with corrections of any values that were abnormal, provide analgesia as needed. He was on clopidogrel, which I had mentioned previously in his medication list. That was to be held, and he was to be placed on just enoxaparin. The amiodarone was to be discontinued. Cardiology is to be consulted, and if there were any tachyarrhythmias which actually persisted despite normal electrolytes, we were to consider epidural sympathectomy. Now, moving into the ICU unit, this is when our patient has actually gone from the emergency room to the ICU. He was reviewed by cardiology, and their plan was to recommence the amiodarone, loading him with 900 milligrams over 24 hours intravenously, then switching to an oral regimen at 400 milligrams 3 times daily for 2 days, 400 milligrams twice daily for 5 to 7 days, and then a 200 milligram maintenance. He was to maintain the aldactone, which he was on, until the potassium had normalized, and then they were going to half the dose. The digoxin, once the potassium levels have normalized, fluid restrictions, holding magnesium, and performing daily lab investigations, and to continue his sacubitril and valsartan combination. Okay, so now we're moving a little bit further into the events that happened within the ICU. So as you can see here, we have the times as they are related. On the 31st at 7:40 in the morning, our patient had decreased responsiveness again. He was noted to revert or to switch into VTach at a rate of 219 beats per minute, and then had reverted to VFib. ACLS was again instituted, and the patient was shocked, and ROSC was achieved. He was stable until the evening on that same day, about 9:35, in which again a similar event had occurred. But at this point in time, the patient of note was decided to, the team had decided to intubate the patient. And as we move forward in time, on the 1st of August, in the wee hours of the morning, at 6:32, our patient had his sixth event. Again, displayed, not just decreased responsiveness, but he was He had displayed VTAC on the monitor at 251 beats per minute. He had then reverted to VFib, sorry, not VTAC, and ACLS was instituted. The patient was shocked, and post arrest, the patient actually displayed sinus bradycardia, and that then spontaneously reverted to normal sinus rhythm. Due to the fact that at that time, the patient was significantly hypotensive at a BP of 72/41 with a MAP of 51, it was decided to commence Levophed at an infusion rate of 0.05 mics per kg per minute. So at this time, I will pause and like the audience to think of what else they would have liked or what else could have been done. Not, I shouldn't say could have been done, what else will be done or should be done next for this patient. Okay, I'm going to turn over my presentation to Dr. Bernard and allow you to mull on that. And there we go. Thank you very much.
Okay. Right, so this part of the presentation, we'd like to open the floor for any questions for the presenter. Would also like to remind the persons who are on, who was logged in, to put their name in full with the allotted code number that was given to them to signify or to signify to us that you require CMEs with this presentation. All right. Okay.
Hi.
So just checking the chat here if there's any questions for the presenter.
Do we just go ahead and ask a question or do we type it? Hello?
Are there any questions? All right, so since there's none so far from my presenter, he did an amazing job, Dr. Waldron. And we're gonna go over now to our resident of the year nominee, Dr. Brandon Bernard. All right. What?
Hello?
And I don't
Hi.
understand this.
Okay, I don't think they can hear me. Hi, good day. Can you hear me?
Dr. Patrick?
All right. All right. So we have one question from the audience, um, asking Dr. Waldron, what was the plan for the suppression of the ventricular tachycardia at that time?
Hi, good evening again. With respect to the question, I believe the plan was to normalize the patient's electrolyte panel. And with that, he would have been commenced on antiarrhythmics to prevent any subsequent occurrences of VTAC.
Any other questions?
Are there any other questions? It doesn't seem to be any other questions. Dr. Claire Pascal.
Are you hearing or nothing? No, I don't think.
All right. So
Hearing
if
me?
there are no more questions, we're going to go ahead and we are going to go into the discussion of the case with Dr. Bernard at this time. Dr. Bernard?
Hi, good evening. So I hear that there's someone who's trying to ask a question. Dr. Claire Pasco, can you hear us? No? Not hearing
Dr.
any.
Bernard.
Hi, good evening.
Hi, Dr. Edwards. She was asking if there was any use of a beta blocker.
Okay, I'll let the presenter say that.
Yes, the patient was maintained on his usual medications. He was actually on carvedilol and bisoprolol, to be honest. And I didn't see any specific mention of using the beta blockers as a means to abort any events. It was just maintenance of his routine medication.
Okay.
Hello?
Yeah, we're hearing you, Doc. Dr.
Oh,
Claire
you're
Pasco?
hearing now? Oh,
Yes,
hi.
we are.
Okay, thanks. In terms of thanks for answering the question. In terms of the beta blocker usage, I wasn't sure if it was added, but we tend to, metoprolol as a beta blocker as a little superior effect in my eyes, for rate, as it relates to rate, and ideally, we like to use, we don't have the IV version, unfortunately. But the oral metoprolol probably would be another option. And I'm not sure about the sedation and if there was any thought to actually intubate the patient, because one of the things that you actually would want to do is to ensure that there is less adrenergic drive. So, dark room, patient deeply sedated, you're gonna be continuing the IV. I know that they had the patient on IV amiodarone. I'm not sure how long the patient was on IV infusion amiodarone, if you could speak to that, and if there was actually any thought of using the oral and the IV amiodarone, and then, as like a bridging thing, and then you step down to only oral. do you know how it went in terms of the discontinuing and the recontinuing of the amiodarone?
So with respect to your question, the patient was commenced, I believe when cardiology had first reviewed him upon entering the ICU, there was a plan for IV loading with switching to an oral amiodarone regimen, step-down therapy, with the 200 milligrams of maintenance after about a week, I believe. So next question.
Any plans for, do you know if there was any discussion around, intubating the patient and deep sedation and etc. And yeah, basically.
Deep sedation? I'm sorry, you said deep sedation?
Yeah, and intubating the patient, seeing that he was, in an electrical storm. I'm not sure if you were managing and have any idea if there was any discussion around that.
The patient was intubated after, I believe, the 5th arrest, but I don't recall reviewing anything in the notes regarding any plan for deep sedation or as a way in which to abort or mitigate the adrenergic drive.
Thank you.
I believe the amiodarone was stopped. I think someone had asked the question in terms of why was the amiodarone stopped. I believe it was stopped. There was a plan to stop it, but it wasn't actually stopped. It was continued while the patient was in ICU.
All right. We are going to go ahead. We're a bit over our time now. So we're going to go into the discussion with Dr. Bernard. We can take questions afterwards. All right.
All right, good evening, everyone. I hope you guys can hear me. Can everyone hear me fine? All right, so welcome again. I'm Dr. Brandon Bernard. I'm a 4th-year resident here at the University Hospital of the West Indies, and I'm studying emergency medicine. Today, I'm going to be giving the discussion portion about calming the storm, a bit of updates in the management of refractory ventricular tachycardia and ventricular fibrillation. So we have some objectives that I'd like to achieve today. First, we are going to define electrical storm. We are also going to discuss the chain of survival, and we're going to briefly review the pathophysiology of ventricular tachyarrhythmias. And hopefully that gives us some insight about how they can be managed. We're going to discuss the most common arrhythmias seen in an electrical storm, as well as list the reversible causes of electrical storm. We're going to briefly review the ACLS protocol, although this is not an ACLS protocol discussion or training session. It's very important that we discuss this because it's the backbone of cardiac resuscitation. And we're going to go a bit beyond ACLS into no man's land. So we're going to discuss novel treatments in patients with electrical storm, as well as to describe some of the goals of post-resuscitative care. So electrical storm, as many of you guys got correct in our little questionnaire, it's an increasingly common and life-threatening syndrome that is defined by 3 or more sustained episodes of ventricular tachycardia, ventricular fibrillation, or appropriate shocks from an implanted cardioverter defibrillator within 24 hours. And this is one of the most common definitions that I've seen in the literature. This is from Eifling et al., 2011, Texas Heart Institute Journal. but there are many other definitions that are out there. So there's no consensus about what electrical storm even is. So some say it's 2 or more occurrences of ventricular fibrillation or ventricular tachycardia in 24 hours. Some say 3 or more. Maybe it's 2 episodes. Maybe it's any time anyone gets shocked by an implanted cardioverter defibrillator. So there's many definitions, but this is the most common. Electrical storm, the rhythm really matters. So the incidence of the different rhythms are here. The most common by far is going to be your monomorphic ventricular tachycardia, and that occurs in 86 to 97% of cases. Other rhythms that can occur is your polymorphic ventricular tachycardia, as well as ventricular fibrillation. And of course, there are cases where you end up with a mixture of ventricular fibrillation and ventricular tachycardia. So the most common is the monomorphic ventricular tachycardia. So for this to occur, you need to have a vulnerable substrate, so injured myocardium. So there may be an ischemic insult to the myocardium, or there was a myocardial infarction, which resulted in scar tissue formation. And that then creates areas of conduction block. So conduction block is very important. Next thing that needs to happen is a triggering event. So the patient may experience a PVC that triggers them into the dysrhythmia, or there may be an underlying electrolyte imbalance. But basically what happens, I hope you guys can see my cursor. What happens is there is electrical depolarization that encounters an area on the outside of the injured tissue. So the scar is in the middle. On the outside, you have a mixture of scar and normal myocardium. And that creates an area where there's a conduction block. So you can't get from point 1 to point 2 because you're running into this area that doesn't conduct electricity. So what then happens is the electrical potential or conduction will go and find a circuit. And then every time you go around this circuit, you will depolarize the ventricular myocardium, and you end up with a QRS complex that's very wide. This wide QRS complex, of course, is because you're not using any fast conducting pathways. So you end up with a monomorphic ventricular tachycardia, because each time you go around this circuit, the heart depolarizes in the same pattern. That's monomorphic. Polymorphic ventricular tachycardia involves some of the same things. So you're going to be forming circuits, but there's more than one focus, there's more than one exit in the myocardium. So depends on which circuit is used or which circuit the heart depolarizes with, the QRS looks a little different each time. And this can happen in patients with organic heart disease, for example, myocarditis, hypertrophic cardiomyopathy, or ischemic cardiomyopathy. But it can also occur in the absence of any structural heart disease, like patients with an electrolyte abnormality, let's say. So here's a schematic showing how these circuits can get a bit complex. And we can see here there's multiple ways that depolarization can go around these scar tissue, creating multiple loops. There's multiple exits. And each time the heart depolarizes, the depolarization takes a little bit of a different route. So each QRS complex looks a little different. Polymorphic ventricular tachycardia does not only occur with an association with prolonged QT, but the one that happens with prolonged QT is special to us, and we call it Torsades de Pont. So who is at risk for electrical storm anyway? Turns out a lot of patients have damage to their hearts to begin with, right? So these aren't going to be your usual healthy people in the majority of cases. You will have persons with ischemic heart disease or persons with a history of myocardial infarction, usually with low ejection fractions, and persons with decompensated heart failure are at higher risk, so your New York Heart Association class 3 and 4. Of course, you require structural heart disease in some cases, and we said that structural heart disease is what forms these abnormal circuits to create the substrate that will be vulnerable to the creation of these conduction abnormalities. Patients with renal failure are at increased risk for electrical storm. So we know that these persons at times may have had underlying hypertensive heart disease, which in addition to damaging their kidneys can damage their hearts. And they're also at risk for electrolyte abnormalities. So we said that that was a potential trigger for these. So it's not so surprising that patients with renal failure are at risk for electrical storm. Now, patients with implanted cardioverter defibrillators are really high risk. And this makes sense because these persons are selected to get this procedure, this device implanted, because they're at risk for developing abnormal heart rhythms. So we can see in the first study by M. Kanju et al. That of all persons with an implanted cardioverter defibrillator during their lifetime, 10 to 20% of them will experience electrical storm. And another major study that was done, the MADIC-2 study by Sasselberg et al., published in the journal Heart Rhythm, 2007, shows that 4% of patients with internal implanted cardioverter defibrillators have electrical storm within a 20-month period. So patients with ICDs are at high risk of experiencing electrical storm. Now, electrical storm is bad because it kills people. So the MADIC-2 trial shows that persons that had electrical storm when compared to persons that were controlled for similar comorbidities and age, they had a 7.4-fold higher risk of death. And we know from the AVID trial at the bottom by Exner et al., Circulation 2001, that these patients don't only die from sudden cardiac death, they're at risk for dying from a number of different reasons. And their risk of dying from a non-sudden cardiac death cause is still 2.4-fold higher than the average population of persons that have not experienced electrical storm that have similar comorbidities. Now, patients with electrical storm, they're going to present similarly, regardless of if they have an ICD or not. They're going to experience palpitations, pre-syncope. They may even syncopize. They may have chest pain. They may have dyspnea. But with the ICD, the one symptom that is going to happen in them, but not other people, is that they may be experiencing their device firing. So they are being defibrillated by this device in their chest. So that's what's going to be different about them. Now, if someone comes into your emergency room or hospital or clinic, and they're experiencing their device shocking them, that may be an appropriate response to an abnormal heart rhythm. But if you are going to be proceeding with cardiac resuscitation, one thing that could be done or should be done in some cases is to place a magnet over the device. And what this does is deactivates the device's defibrillation protocol or programming, but it will not stop the device from pacing the patient. Once you've stopped the device from delivering shocks, you can then proceed with your resuscitation. And of course, patients with electrical storm may just present in cardiac arrest. So one thing that's very important about cardiac arrest, and that we know from the literature, is that the chain of survival is very important. So you want to recognize the situation as early as possible. If they're in hospital, you want to be able to prevent them from going into cardiac arrest. You want to activate the emergency response system to get them the help that they need as soon as possible. But the most high evidence that we have for saving lives, despite all the fanciness that we're going to be talking about in the next few minutes, is high quality CPR. That is a level 1 recommendation. Anyone in cardiac arrest should get high quality chest compressions. And of course, especially when they have a shockable rhythm, you need to consider, well, you need to give early defibrillation. So both of these are level 1 recommendations from the American Heart Association. AHA doesn't give out level 1 recommendations very frequently. So these are some of the only 2 level 1 recommendations we have for emergency cardiac care and cardiac resuscitation. Now, the importance of chest compressions is because there is a direct correlation between coronary perfusion pressure and achieving ROSC. We know that in patients that have very low coronary perfusion pressures, they don't achieve ROSC. And we know that when you are able to deliver high quality chest compressions, your coronary perfusion pressure goes up. So in the green is where your coronary perfusion pressure would be during chest compressions. And as soon as you stop chest compressions for a rhythm check or any other reason, really, your coronary perfusion pressure plummets. And it doesn't go up immediately after chest compressions are resumed. It takes a few cycles before you increase your coronary perfusion to where it was before. Now, this coronary perfusion pressure is very important because we've described before that a lot of these patients are experiencing their arrhythmia because of myocardial ischemia. So you want to deliver blood to the myocardium, and you do that by increasing your coronary perfusion. So pro tips, you want to minimize any interruptions in chest compressions to start off. So we need to rehearse and get this down to a very orchestrated science. We want to be like Formula 1 race car drivers when they pull into the pit. Hands should be off the chest for the minimum amount of time, and that's only to allow rhythm recognition and shock delivery. Unless you're trying to achieve one of those 2 things, delivering a shock or recognizing a rhythm, chest compression should be ongoing. And another pro tip, you can charge a defibrillator before the rhythm check. So that is a strategy that is used by some persons to try and minimize interruptions in chest compressions to maximize coronary perfusion pressure and maximize the patient's chance of achieving return of spontaneous circulation. So we're going to be going into ACLS in a second. Now, ACLS is the cornerstone of cardiac resuscitation, but it's not the only guideline. The Europeans have their European Society of Cardiology guidelines, which also produces algorithms. But on this side of the world, we more frequently use ACLS. And it's really good because it gives a common language in the treatment of cardiac arrest, and it helps us to avoid paralysis in an otherwise crisis situation where someone's actively dying in front of you. Now, ACLS is an algorithm that is used by specialties across medicine. So if someone goes into cardiac arrest on the psychiatry ward, the psychiatrists are going to use ACLS. Now, psychiatrists are great, but thankfully they don't have to deal with cardiac arrest so frequently. We, in emergency medicine, are probably the specialty that does cardiac arrest most frequently. There's a lot of other specialties that are really great at this as well. So I'm not going to say emergency medicine, but anyone who's a skilled resuscitationist should aim to have a more sophisticated approach. Now, ACLS is the backbone, and it is an international standard, but I believe that there are things that a skilled physician can do to help tailor the care from an algorithm and apply it to a patient in front of you. Now, of course, start with the basics. If someone comes in and they're having chest pain or you think they're in cardiac arrest, the first thing you do is check for responsiveness, check for a pulse. If there's no pulse, start chest compressions. Everyone knows what to do. If they are hypoxic, you can give supplemental oxygen. You want to maintain the saturations at least above 95. And if you need to manage their airway, you can secure the airway. However, if you're going to be intubating the patient, take precaution because a lot of the medications that we use for induction and paralysis can affect the patient's hemodynamics. And of course, if they're in cardiac arrest, that is something that needs to be considered. Once that is achieved, attach a cardiac monitor. Right? Oh, and of course, remember COVID, so you need to take your PPE precautions, right? If there is a pulse, this is a ACLS algorithm for tachycardia with a pulse. Now, you will see the levels of recommendation for cardioversion, procainamide, and amiodarone. The best treatment that we know, or the most effective treatment that we know, and this is not only for patients who are unstable, meaning that they have hypotension, altered mental status, signs of shock, ischemic chest discomfort, or heart failure. The most effective treatment that we know, according to the American Heart Association, is cardioversion. However, that is painful. You are shocking the patient. So persons tend to leave that to be the first method of choice when the patient is unstable. And remember before that our most commonly seen dysrhythmia is going to be your ventricular tachycardia. So if that is so, you'd expect a wide QRS complex that is fast and that is regular. And if they are unstable, you are going to synchronize cardiovert them with 100 joules to start out with. If the person is stable, or if they're refractory to shock, there are medications that can be used, procainamide and amiodarone. Now, there's some literature that we're going to be discussing in a second to suggest which of these two is probably the best to start out with. But in my short experience here at the University Hospital, amiodarone seems to be the one that is most readily available to us here in the Caribbean. Of course, if there's no pulse, you're going to start CPR immediately. And you are going to identify if there is a shockable rhythm. And if there is, you're going to shock them. However, in patients with refractory ventricular tachycardia or ventricular fibrillation, we need to consider whether or not they really need a milligram of epinephrine every 3 to 5 minutes. And we're going to discuss this in a second as well. Maybe that's not the best thing for our patients in refractory ventricular tachycardia, ventricular fibrillation, electrical storm. I just want to mention this 12-lead ECG that some will say should not exist. Now, you don't need a 12-lead ECG of ventricular fibrillation. If you see this rhythm on your cardiac monitor, the next step is going to be to check for a pulse to ensure that they really are in VFib, because VFib never is going to come with a pulse, and start chest compressions. If you see this rhythm, the next step is not going to be to confirm it in another 11 leads. So I don't know what the situation was around this ECG, but pro tip, please don't do a 12-lead ECG to confirm ventricular fibrillation. So a lot of different rhythms can look similar, and anyone who's just learning how to recognize cardiac arrhythmias will struggle with this little conundrum here. Wide, fast QRS complexes. Now, this can be ventricular tachycardia. The problem is a lot of other things can look like ventricular tachycardia. So if you have a supraventricular tachycardia with aberrant conduction or bundle branch block, that will be wide and fast. If you have someone with atrial fibrillation with a bundle branch block or Wolff-Parkinson-White, or pre-excitation as it's called, that will be wide, irregular, and fast. So my colleague mentioned some algorithms that are present. They've been described by electrophysiologists who have been trying to differentiate these different rhythms, SVT with aberrancy versus VT for centuries, well, probably not centuries, for years. And they're not perfect. So some of the things that you look out for is the absence of a typical right bundle or left bundle morphology. If you look and you see that there's AV dissociation, meaning that you can see P waves just sprinkled out throughout the QRS complexes, as you see here, those are some features that suggest that you're dealing with a ventricular tachycardia. Other things that you can look out for are narrow QRS complexes, which are interspersed. between the wide QRS complexes. Those are called captured beats. And you can look for these, which are fusion beats. They're kind of halfway between a normal captured beat and a idioventricular beat. And of course, you can look for concordance in your leads. So those are some things to look out for. Now, there is a mention in the algorithm from ACLS that you can consider adenosine if the rhythm is regular and monomorphic and wide. This is a study by Marl et al. And what they did, they took persons with a wide, fast, regular dysrhythmia, and they gave them adenosine, and they basically tried to determine who converted and who didn't. And turns out that is a treatment for SVT, so big surprise, everyone with SVT, well, almost everyone, 90% of persons converted if they had SVT. If you had ventricular tachycardia, you were much less likely to convert, and only 2% of those converted. The light at the end of the rainbow for this study is that there were no adverse events present. So if you're in a pinch, you don't know if you're dealing with SVT or VT, technically the algorithm says you can try the adenosine. However, if you're not sure, it's much safer just to treat as ventricular tachycardia. The reason being, supraventricular tachycardia might resolve with treatment for ventricular tachycardia. It's not the same the other way around. If someone has ventricular tachycardia and you give them a treatment for SVT, for example, verapamil, you can precipitate a cardiac arrest and kill the patient. So it's probably safest not to kill the patient. And this is from a study, an article, Differentiation of Ventricular Tachycardia from SVT in Annals of Emergency Medicine, way back in 1987. So the mainstay of all treatment strategies that we have in medicine is if there's a trigger, treat the trigger. So some things to consider are electrolyte disturbances like hypo or hyperkalemia, hyperphosphatemia, hypomagnesemia, and you'd recognize those as causing prolonged QT. And if the person has new or worsening heart failure, acute ischemia, thyrotoxicosis, infections, if they're febrile or they're using cocaine or some other drug, you might want to address those triggers to help the patient recover. And a special mention, there are persons who have inherited sodium channelopathies, and those persons are going to be treated a little differently than others. So persons with Brugada syndrome, there's 3 different Brugada patterns that you can recognize, type 1 to 3, but just keep in mind that these persons are treated a little differently, and isoproterenol and quinidine helps them. Now, as we mentioned before, one of the antidysrhythmics that we use most frequently is amiodarone. It's near and dear to every cardiologist's heart, I'm sure. There is some literature that has gotten it some very good recommendations. So Levine et al. Studied amiodarone and found that in patients with refractory ventricular fibrillation and ventricular tachycardia, so it's going to be a throwback. This is persons that were refractory to lidocaine and beryllium. 40% persons that were refractory survived at 24 hours when given amiodarone. So amiodarone has a level 2B level of evidence B recommendation. Now, if we look at what that translates to, the American Heart Association says that that is a weak recommendation. And the evidence that we have is randomized. So there's already some question marks appearing. We know that amiodarone decreases ventricular tachycardia episodes. So this is a study that was done, published in 1995. And what they did, they had 132 patients with incessant ventricular tachycardia, meaning that they had 2 or more episodes of hemodynamically destabilizing ventricular tachycardia in 24 hours. Well, incessant ventricular tachycardia means that the tachycardia didn't stop. And they also included persons with 2 or more hemodynamically destabilizing ventricular tachycardia in 24 hours. And they gave them an amiodarone and looked to see what happened. So they basically compared the number of episodes of VT or VF that they had in a 24-hour period. And then they gave them amiodarone and saw how many episodes they had after the amiodarone. And they found that the episodes decreased when they were given amiodarone. So that's another reason why we use amiodarone. Now, this study calls into question the use of amiodarone altogether, in my humble opinion. So this is the ARREST trial. And basically, they gave persons with out-of-hospital cardiac arrest amiodarone, and they found that it worked. It got you to the hospital alive. So it increased your survival to admission. Here's a part that calls into question the use of amiodarone. Patients don't necessarily care as much about arriving to hospital as they care about getting discharged from the hospital. And when this study was done, it was shown that amiodarone does not increase your survival to discharge. Meaning that if you were going to die without amiodarone, when we gave you amiodarone, you got to the hospital, but you died anyway. So question mark about amiodarone. Now, Dr. Pascoe earlier made a comment about catecholamines triggering ventricular tachycardia or electrical storm, and that is quite right. We know that catecholamines can trigger dysrhythmias. So here are two studies that show arrhythmias that are induced by catecholamines. We also know that electrical storm, in a lot of cases, involves ischemic myocardium. We know that high doses of epinephrine can constrict blood vessels, of which the coronary arteries are blood vessels. So giving high doses of epinephrine will possibly constrict your coronary arteries and decrease coronary perfusion. That's bad. We also know that epinephrine will increase your ventricular rate, which will increase your myocardial oxygen demand, and that sounds pretty bad as well. So if ischemia is what's underlying these dysrhythmias and we're trying to treat the underlying cause, maybe we are just doing the wrong thing. We are adding gas to the fire. We are making things worse. The heart is lacking oxygen, so we do things to it that makes it need more oxygen and cuts away its oxygen supply. So maybe we should be thinking twice whether our patients with refractory ventricular or electrical storm really require high doses of epinephrine. And Dr. Pascoe rightfully mentioned the benefit from sedation in patients with refractory ventricular or electrical storm. Turns out cardioversion hurts. You're shocking the patient, that causes pain. Of course, they are going to be very anxious because their heart's going a mile a minute and they don't know what's going on. So they're going to be in a ramped up high catecholamine state. Sedation helps to decrease that endogenous catecholamine surge. And by decreasing the catecholamine surge, it increases your chance of achieving ROSC. So you can use any form of sedation that you feel comfortable with, but here are some options below: fentanyl, midazolam, ketamine, and morphine. I just want to add, though, that take some precaution. You need to be very familiar with the hemodynamic effects of these medications if you're going to be sedating a patient who is peri-arrest. Now, one of the big discoveries recently that I think maybe might make it into an algorithm in the near future is the use of esmolol. Esmolol does what no other drug we know about in cardiac arrest does. It increases your chance of neurologically intact survival. The study was done by Driver et al. Now, it does have some critiques to this study. They didn't have huge sample sizes, but it's a small study with some very, very big results. And they were statistically significant results. So we all know esmolol is a fast-acting beta blocker. So it helps to work against some of the effects of these, the catecholamine surge that occurs in electrical storm. And they gave patients esmolol and compared it to a cohort of patients who received standard ACLS treatment only. And what they found was astonishing. 50% of persons that received esmolol during their cardiac arrest survived neurologically intact, versus only 11% in the person that just got standard ACLS treatment. Now, that is big. That is a patient-centered outcome that we should all pay attention to. Our patients want to live and they want to be neurologically intact and they want to have the best chance that they have of continuing their lives in a way that as closely as possible resembles their premorbid state. So this is something we should really consider. And it wasn't just shown in one study. Here's another study, this one from Lee et al. And the dose that they gave in both of these studies was 500 micrograms per kilogram load. And then depending on their hemodynamic state, they may or may not have received an infusion of 0 to 100 micrograms per kilogram per minute. The study showed that sustained ROS was significantly increased in the esmolol group compared to the control group. We don't have esmolol, or I haven't seen it in our emergency room, but based on this evidence, maybe this is something we should consider offering our patients. Now, we showed before that the algorithm in ACLS recommends these two medications, procainamide and amiodarone. However, it doesn't give any clear indication as to which one of these is better than the other one. But we have some evidence, the ProCameo study. And what this study did, they included 62 patients with stable ventricular tachycardia, and they compared persons that were given procainamide to persons that were given amiodarone. So this is a direct head-to-head comparison. And what they found was that the procainamide was associated with less adverse events. So 18% of persons with procainamide had an adverse effect versus 31% in the patients that received amiodarone. And the most frequent adverse effect was hypotension in this study. And they also showed that procainamide just worked better. 67% of persons that received procainamide converted in a 40-minute period versus only 11% in who received amiodarone. The drawback though, you'll see the dollar signs at the top of the screen. Turns out procainamide costs 4 times as much as amiodarone, but that's because it works better. You get what you pay for, guys. Another thing that's coming out now, cutting edge stuff, is double sequential defibrillation. Now, anyone who has seen the new 2020 ACLS guidelines saw that this got a level 2B recommendation, but based on very low quality evidence, it is not recommended as first line. It is not recommended based off of their literature review, which did not include this study that we see here. So what double sequential defibrillation is basically using 2 defibrillators, and you are applying 2 different sets of pads or applying your paddles in 2 different places. And that is to achieve more than one energy vector. So if you have a defibrillation shock that's delivered, you will get a portion of the myocardium to depolarize. Using more than one vector aims at depolarizing a greater percentage of your myocardium, which will increase your chances of converting the rhythm. And what it found in this study was that 80% of patients who were refractory to depolarization with one vector or standard defibrillation with one machine, 80% of those who were refractory converted with double sequential defibrillation. So here are some different options where you can put your pads or paddles. So you can have the blue at the top left, where you have your standard chest and apex, as well as your anterior posterior. Or you can do side by side but not touching, which is the second picture. And basically, you aim to deliver the shock simultaneously. So you'll charge both machines and you'll press shock on both machines at the same time. And that's the level of evidence that we have. This study was a feasibility study. So it's being followed up by a much bigger study. And we hope to get the results from the big boy study that they're following it up with next year. So keep an eye on the horizon. Maybe this will prove to be beneficial for our patients. We hope so. All right, so if you've shocked your patient, you've given amiodarone and or procainamide, hopefully if your hospital has it, and you're still refractory, something that you can consider is sympathetic blockade. And here's a study by Kunlawi et al., published in Circulation in 2000. And what they did was gave patients one of two different methods of sympathetic blockade. They either gave propranolol at 0.15 milligrams per kilogram IV over 10 minutes, and then Q 3 to 5 minutes IV every 6 hours, or they gave a left stellate ganglion blockade. So what is a left stellate ganglion blockade? Let's start with some throwback material from med school days. We all remember that the autonomic nervous system is one of the ways that the body regulates the heart rate. So if you have high sympathetic tone going to your SA node, your heart rate goes up, and that is the occurrence or the effect of the sympathetic chain. The heart is innervated by the sympathetic chain, particularly the stellate ganglion. So we can see the stellate ganglion. Where's my mouse? Can you guys see my pointer? I hope so. This is the stellate ganglion. It is just anterior to the transverse process of C7, and it is anterior to the muscle here, which is called the longus colli muscle. This stellate ganglion blockade can be done under ultrasound guidance, and it doesn't take very long in the hands of a skilled physician. Disclaimer, I've never done this, so consultants, don't worry. But it does utilize some of the skills that we use in the emergency room. We do use ultrasound guidance to place IVs, and we are able to use ultrasound to identify some structures that maybe we shouldn't put a needle in, like the carotid artery, the thyroid gland, the esophagus. But avoiding all of those structures, you are able to use medication that we know very well, lidocaine, that can affect nerves, like pain receptors that we do all the time, but applying it to the sympathetic chain will help decrease the catecholamine or sympathetic tone going to the heart, and it's been shown to help patients recover or survive electrical storm. This is the same study from Kunlawi et al., and basically it's showing that persons that got sympathetic blockade, we can see that of 49 patients that they had, 27 were randomized into sympathetic blockade, 22 just got standard ACLS, and look at this, 21 patients that got sympathetic blockade survived, whereas only 4 patients that got standard ACLS survived. This is something we have the capability of doing in the emergency room, not necessarily the stellate ganglion block, but certainly we have propranolol, which is one of the methods that they use for sympathetic blockade. And possibly we can get our hands on esmolol because we've already shown some benefits of that medication. But what we are trying to achieve is getting down to survival. So at 1 week survival, 21 people out of the 27 survived, and 18 survived after a year. Survival was abysmal at 1 year in the standard ACLS only. So this is something that we can consider to do for our patients. Propranolol, who knew? All right, another thing, thoracic epidural anesthesia. So this is not something we do in the emergency room, but it is something that our colleagues in anesthesia may be able to help us with. And it has been shown to decrease arrhythmias in 75% of patients with refractory ventricular arrhythmias. Now that is a very high number, And I think it has to do with the sympathetics innervation to the heart. So this is another novel treatment that can be considered, although it's not so novel anymore. This study was from 2010. Intra-aortic balloon pump. So believe it or not, we actually have this capability at the University Hospital of the West Indies. They have the machine in ICU. And what this has been shown to do is increase coronary perfusion pressure, which we know is associated with ROSC. And it relieves ischemic substrate. So it takes some of the pressure off of the heart, so it decreases oxygen demand. And it also may be anti-arrhythmogenic directly. So there's been studies that have been shown that it works even in hearts that have normal perfusion. So intra-aortic balloon pump is something to be considered in refractory cases. And here's a study by Fotopoulos et al. From the Heart Journal in 1999. And this study showed that it stabilized 85% of cases that were included in the study. Now, only refractory ventricular arrhythmia was included in this study. So it was a very sick patient cohort to start out with. But nonetheless, 85% of cases stabilized. 66% of cases were cured of their electrical storm permanently based off of this. And 19% of their patients, it decreased the arrhythmia burden by 19% in the cohort of patients in which it wasn't permanently curative. And this study was done and reported no complications from their use of intra-aortic balloon pump. So it appears to be safe. Percutaneous left ventricular assist devices are actually a standard in the European guidelines. So the 2015 ESC guidelines for the management of patients with ventricular arrhythmias and prevention of sudden cardiac death gives LVADs a level 2A recommendation based off of level B evidence. So it has been shown to help patients survive their electrical storm. Now, of course, this isn't going to be something that we can just do on everyone because these devices are very expensive and not usually available in the emergency department, but it is something that is done in the world. It is described in the literature. And the picture on the left, I think, is really cool. This is the Impella device. And basically what you do is you do an arterial puncture in the femoral artery and you thread this device up through the aorta into the left ventricle. And what it then does is takes blood from inside the ventricle and pumps it across the aortic valve into the aorta. And that helps to support the heart and allows these patients to survive. Now, the last ditch effort is a surgical procedure, which can be done. This is the, remember we were talking about the sympathetic chain before? What they do in this surgery is to excise a part of that sympathetic chain. And it was shown to decrease the episodes of ventricular arrhythmia by 56% of patients who had this procedure done. Now, the goal of all of this is to get patients to the cath lab alive. So you should be involving your cardiologist or your electrophysiologist as soon as possible, because if your heart, if the patient's heart has any fixed coronary lesion or they are ischemic because of poor perfusion, they may require stenting. And electrophysiologists may be able to go into the heart. And remember, we were talking about those abnormal reentrant circuits. They can use radio frequency ablation to just ablate that area and prevent any further dysrhythmias from occurring. So big up to the cardiologists. Okay, getting to the end, guys. So this is a very good summary that I saw in the paper from Eifling et al. In 2011. And it basically gives a treatment strategy and it lets you know that there are different methods that can be done to treat the different types of arrhythmias that we see here. And we've talked about most of these already in some form. Now, after you've achieved ROSC, remember that you're definitely going to high five your coworkers, but the work is not done. You need to remember, manage the airway, obtain a 12V ECG, check if the patient is able to follow commands, and consider targeted temperature management. So you're also going to have to address your reversible causes at this point as well. And remember that a patient's road to recovery begins after ROSC. So once you've achieved return of spontaneous circulation, they still have a long road to recovery, and they will still need you to be able to support them. So remember, please, after you've achieved ROSC for your patient, they will need a formal needs assessment to assess their physical, psychosocial, and cognitive needs. And these are my references. I have quite a bit of them. I know you guys probably can't read all of this, but I'm just going quickly. The end. That's all, folks. Any questions?
All right. Thank you again, Dr. Bernard, for that comprehensive presentation. So we're going to open the floor. I just want to read, some questions from the presenters. So the first question that we have is they're asking about the use of verapamil in these patients.
All right, thank you very much for that question about verapamil. I'm not a cardiologist. I have not seen verapamil in the reading that I did for this presentation, but I'm sure that maybe someone else might be able to contribute. I know that verapamil is a calcium channel blocker. I did not see that in my reading. Perhaps Dr. Claire Pascal might be able to give some input for that question.
Sure. Typically, we don't give verapamil for these patients. There are very few cases of VT, like your fascicular VT, in which that would be given, and some RVOT, VT, etc. But I think in terms of a decision to do that, it should be at the level of an electrophysiologist, because that really would need to be a certain, either through the electrophysiologist study during the time of ablation, or very detailed review of the ECG. So usually off the bat, no, we do not recommend that.
Or I think it's an answer. Dr. Claire Pascal, can you hear us?
Yes, did you hear me?
Yeah,
Yes.
thank you very much for that response.
Oh, okay, thanks.
Dr. Waldron has something to say now.
Dr. Claire Pascal?
Pardon? I answered. I'm not sure if you asked another question, but I only heard Dr. Bernard's question, the question that was sent to Dr. Bernard about the verapamil, which I just answered. I'm not sure if you heard it.
Yes, are you?
I don't think she's hearing.
Uh, the next question was in regards to the mechanism of action of esmolol and how does it improve the neurological function in these patients.
So thank you for that question. So based on my reading in the evidence, I don't think we have a very clear-cut answer to exactly how esmolol increases your chance for neurologically intact survival. We know that it's a short-acting beta blocker, and as such will have an effect on the heart, meaning that it will help to counteract some of the effects of catecholamines on the heart. And in doing so, based on the studies that we've done, we've observed that these patients have an increased chance of neurologically intact survival. As it pertains to whether there's any action on the brain itself, I have not seen that in the literature, but we do know that it helps to increase the chances of return of spontaneous circulation. And we do know that it helps to preserve return of spontaneous circulation. And once there's spontaneous circulation, there is increased cerebral perfusion. So there is less of an insult to the brain. However, that said, while that makes physiologic sense, I have not seen any trial, and I don't think any trial will be forthcoming to definitively say that esmolol has any physiologic effect on the brain, because these are very unstable patients and you will not be able to do any randomized controlled trial to establish any cerebral effect or help to demystify exactly how esmolol increases neurologically intact survival. However, as it pertains to our clinical decision making, I think the results that we have in the literature suggest to us that maybe esmolol is something we should consider for the benefit of our patients.
Can you hear me? Yeah. So there were also a question from the YouTube viewers. They were asking if electrical storm occur in children, and for those that may guess that if there's any recommendation in the pediatric age group.
All right, good evening. So I must admit, I did not specifically look up electrical storm in pediatric population, but I am reluctant to say it does not occur. So I believe that there are inherited channelopathies which can affect persons of all age groups. I did not see any specific evidence speaking to how it should be managed differently in a pediatric population. But certainly it is something worth taking a look at.
Okay, let's check in the chat for more questions. There were a few individuals that made highlight, wanted to know from Dr. Bernard where he got a 12-lead ECG of ventricular fibrillation. Don't really know how that would have been possible, but when it comes to Dr. Bernard, he makes it possible, and that is a very interesting thing to do. Right. So, in terms of further question,
So
right.
as it pertains to the 12-lead ECG, I'm pretty sure no one is gonna fess up to taking a 12-lead ECG of someone in ventricular fibrillation.
Well, persons are asking your source of your ECG, but anyways, there are another question from the chat asking what
It was
about
not from the
use-
University Hospital of the West Indies, I'll say that.
Yes, definitely. What about the use of lidocaine in these patients?
So lidocaine is making a comeback. So we know that lidocaine is a antidysrhythmic, which was used in the past and was displaced when amiodarone came on the line. However, we're now seeing that maybe amiodarone isn't as good as we once thought, and we're going back to go to old faithful lidocaine. So it's a sodium channel blocker, which makes it a class 1 antidysrhythmic. And we know that it has its highest chance of working on ischemic myocardium. So if it is going to work, which it does in about 30% of cases, according to my perusal of the literature, it works very quickly. So if it is going to work, it's worth giving it a shot. Lidocaine won't stay around for an extended period in the circulation, but if it works, why not try?
Right.
Oh, I'd like to add as well that it is once again in the algorithm from the ACLS. So it had been removed for a little bit, but lidocaine is back.
Right. Okay. Just checking the chat again for if there are any further questions for our presenter. Looking back at it. Okay. It seems that we have really interesting run rounds. The knowledge base behind it and the options available to us were excellently delivered in terms of having the knowledge base and the steps of the management options in electrical storm. We hope that emergency medicine or emergency physicians rather are able to look at other options for these patients. And with knowledge comes the ability to further provide options for your patients that present to you. If there are no further questions at this time, okay, so if there are no questions at this time, Dr. Waldron is going to take back the floor just to wrap up our case to see what the results of that case that he presented was. Dr. Waldron?
Can everyone see me? Okay. Good night, everyone. We'll just be wrapping up shortly. I'm certain that I left everyone feeling a little bit this way in terms of this slide. So without further ado, we will get to the conclusion of our very interesting case. We'll move further along on the timeline, where on the 1st of August in the morning, between 8 o'clock and 8:10, our patient unfortunately had his 7th cardiac arrest. It was noted that the patient had a heart rate of 220 on the monitor in ICU. He was defibrillated again at 300 joules, and there was a transient period of sinus bradycardia with spontaneous reversion to normal sinus rhythm. At 8:05, the patient reverted back into VTAC at 207 beats per minute. So at 8 a.m., the 7th event occurred where he had an elevated heart rate of 220. He was shocked, and then subsequently at 8:05, so pretty much right after, he went back into VTAC at 207 beats per minute, was defibrillated, and there was conversion to sinus rhythm. He remained hypotensive at 86/53. And with respect to the Levophed, which was instituted earlier, that was increased to 0.07 mics per kg per minute. So the anesthetic team had rounded, and the plan was for CT brain, emergency angiogram to be done. The Levophed was to be increased to 0.1 mics per kg per minute over 18 hours. There was consideration for lidocaine as well as metoprolol. The metoprolol was actually given. The lidocaine, I don't believe, was actually given. And his target map was to be that of 60 millimeters of mercury. At 10:44 that morning, he again had his next period of arrest with a rapid increase in the heart rate to 232 with precipitous decline to asystole. ACLS again was instituted. Chest compressions at this time were instituted, and the heart rate had actually increased to 200 beats per minute after the asystolic period. So he was rapid at 232, spontaneously went down to asystole, chest compressions were instituted, and for some reason the patient just shot back up to 200 beats per minute and displayed VTAC. He was shocked, and ROSC was achieved at normal sinus rhythm. So the plan, which had previously been outlined for CT brain and angiography, was actually commenced. So between the hours of 11:25 and 1:15 p.m., those were actually implemented. He had CT brain and had actually gone to the cardiac cath lab. And he had angiography performed on the 1st at 12:30 p.m. Of note, there wasn't anything significant found within the vasculature. He actually had angiographically normal vessels. Coming to the end, the patient later on that evening, for the first time, had his first periods of seizure-like activity, which were noted to be lip smacking followed by jerking movements of the lower limbs on 3 separate occasions, which approximately lasted for about 2 minutes. The medication, he was medicated with midazolam, 2 milligrams times 3, which ultimately terminated the activity. And as a precaution, he was loaded with Dilantin, 1 gram IV stat. Now moving to the hours of 9:50 p.m. To 11:07 p.m. Our patient had another set of, another period of cardiac arrest. This time, unfortunately, the patient was noted to go down to a heart rate of 43 beats per minute. Adrenaline times 4 was given. ROSC was achieved. However, shortly after at about 10:02 p.m., at 10:02 p.m., it was noted that ROSC was achieved. Heart rate was sinus rhythm at 77. He was at that time then had his levothyroxine increased to 0.3 mics per kg per minute, and dobutamine was actually added and put on board at 20 mics per kg per minute. Now, unfortunately, at 11 p.m., the patient had his last and final period of cardiac arrest, where the heart rate went down to 33 beats per minute, and then ultimately to asystole. ACLS was commenced, however, at this time it was unsuccessful. So unfortunately, the family was informed, and the patient was pronounced at 11:07 p.m. The patient unfortunately was not able to receive ICD therapy for placement, and was not able to get an epidural sympathectomy. So just in summary, we had a 41-year-old male with a history of dilated cardiomyopathy who had a period of multiple periods of cardiac arrest times 20 prior to arrival. And upon arrival to the University Hospital, had another 10 episodes, which ultimately led to his passing. Of note, he had coronary angiography in hospital, which was angiographically normal. He was then taken to the, he had an autopsy performed on the 4th of August at 9 a.m. And the results of which showed that the patient died of congestive cardiac failure, along with a right lower lobe pulmonary infarct. Along with that, the congestive failure was due to dilated cardiomyopathy. And one thing I hadn't mentioned previously, which was noted on the CT, was that the patient had cerebral edema as well. And that was also found in the on autopsy. Thank you very much for listening to us today on this, with this very, very interesting topic. I'd like to thank everyone. Sorry? Dr. Minnesota Johnson for doing it online. Dr. Minnesota Johnson, I'll pass it back to him. Yes, I just would like to thank the institution and make recognition to you a very wonderful program. It's actually my first time actually ever seeing this case, so big up to the university. Thank you for your attention.
All right. So Dr. Waldron pretty much has, started the vote of thanks. But again, pretty good presentation. And by my watch, it is about 10 minutes after 7, a little bit over our estimated time schedule. But we had a good time. We learned a lot of interesting options that are available to us, an introduction to electrical storm. According to our pilot, some persons just heard about it, about this type of, and some person have never even seen it before. So I hope this session was informative. I would like to thank the doctors that weren't a part but made this available. The Captain-in-Chief, Dr. Rhonda Hudson, also to make available this link. Also Dr. Minnesota Johnson, that was able for us to acquire this session as well, in terms of ascertaining CMEs for all those who has logged on. Also to Dr. Hugh, one of our second year residents who helped with the graphics and the whole presentation. She did a wonderful job. And also I would like to thank in terms of our editing department. Wow, thank you, Dr. Romaine Edwards. Right, she made sure everything was pristine, and we had good support there. So, and again, thanks to the others for an amazing presentation, Dr. Pierre, Dr. Waldron, and Dr. Bernard as well. So also, I know that there are other persons here as well. Dr. Claire Pasco. I would like to apologize for the mistake Dr. Bernard make. There's no Dr. Wright Pasco, right? So, Dr. Claire Pasco, thank you so very much for coming along and giving us aiding your knowledge in terms of having us understanding certain management options and pharmacological options that we have that is available to us. Right. So this conclude our grand rounds on the electrical storm. I hope it was informative. I hope it was interesting. And with that, good evening and goodbye.